Thank you.
Please.
I hope everyone had a very good lunch. I did. I'll be talking today about a very different topic. And again, I appreciate the invitation and the hospitality from the planning committee. I'll be talking about the truth about pancreatic trauma. And the reason that I developed this talk is that there's a lot of controversy and a lot of misunderstanding about what to do when children injure their pancreas. And you heard in the previous talk that the spleen taught us that children's organs shouldn't be touched. And I think that we as pediatric surgeons often cast ourselves as the guardians of children's organs, and that only forces of evil would take out the spleen. So the same must be true of the pancreas, right? No, actually it's different. So the truth number one is that the pancreas is not the spleen, and it needs to be managed very differently. The spleen can be contused, lacerated, or crushed, and the pancreas can be contused, lacerated, or crushed. But the pancreas can also have a partial ductal injury or a complete ductal transection. And this has very different implications, because if you injure the duct, it's going to have a pancreatic leak. There's going to be pancreatic pseudocyst. There's going to be autolysis, or destruction of the tissues around it, and saponification of fat. And all this leads to a very different process than the spleen, which simply bleeds on you. The location of the spleen doesn't really matter much, right? I mean, maybe a little bit, but not the way it does in the pancreas. The pancreas, the location of the injury makes a tremendous difference in how willing we are to operate on it and what the implications will be of surgery. So last year, in 2025, after presenting this in 2024, in 2025, we published a new grading system for the pancreas injury. So the grading system is controlled by the AAST, the American Association for the Surgery of Trauma, and I headed up a committee that basically changed the way that we grade pancreatic injury. And I'll tell you that the most important aspect of that change was that we added subgrades. And so now, instead of simply grading the injury as 1, 2, 3, 4, 5, we have subgrades, and that allowed us to get a little bit more granular with the injury. You don't have to memorize this slide, because I'm going to go through each of these individually. So a grade 1 injury is now a pancreatic contusion without a hematoma. So this is not a laceration of the pancreas. This is the pancreas gets hit and now has a bruise. Okay. So a grade 1A is pancreatic edema or swelling that we can attribute to the trauma, and grade B is the bruise that looks like there's blood in the parenchyma. A grade 2 injury now is a pancreatic injury that is less than 50% of the thickness of the pancreas, or it can be more than 50% the thickness if the duct is proven to be intact. And it can now be in any location. And this injury, a laceration in the head, used to be a grade 4 injury. Those patients actually do very well. And so that's why we changed this definition so that it's a laceration anywhere. A grade 3 injury is still an injury to the main pancreatic duct, but now we specify whether or not they had a study to look at the integrity of the main pancreatic duct. So grade N means that they did not have an ERCP or an MRCP, and a grade 3A is a partial ductal injury, and a grade 3B is a complete ductal transection. So let me show you what this looks like. So here's a CT scan showing an injury that basically goes more than 50% through the thickness of the pancreas. So it looks like a grade 3 injury. Here's the ERCP, and when we eject the duct, what we see here where the blue line is, this is extravasation from the main pancreatic duct. But the orange line shows that the duct is still in continuity. So this is a 3A injury. It's a partial ductal injury. A grade 4, same scheme as the grade 3, but now the injury, instead of being in the neck or the body of the pancreas, is now in the head of the pancreas. So this is an injury that is to the right of the portal vein, or if the portal vein hasn't formed yet, to the right of the superior mesenteric vein. A grade 5 is a destructive injury to the head of the pancreas. So this is typically a blast injury or a crushed pancreatic head where part of the parenchyma of the pancreas is dying or dead. And now the subgrade is whether or not the main pancreatic duct is intact, whether whether it's injured, whether or not the intrapancreatic bile duct is also injured, and then whether or not the pancreas has been avulsed off of the duodenum. So in very severe injuries, especially in children, sometimes we'll see that the duodenum has literally been plucked off of the sphincter vodi. So Truth 101, number one, I want to get out there is that minor pancreatic injuries can be managed non-operatively. And so we're not going to be talking much about these minor injuries. They simply don't need surgery. The first question, though, is how good is CT at identifying and grading the pancreatic injury? And I think this is what's led to a lot of the wrong recommendations, the incorrect recommendations regarding pancreatic trauma. And so we've known for quite some time now, for more than a decade, that CT scanning of the pancreas is not very good. This was adult data, and I will tell you that the data I'm going to show you in a minute is even worse. They found a sensitivity of 47%. For picking up pancreatic ductal injury and or for finding a pancreatic injury, and 52% sensitivity for identifying that the duct was injured. And then the specificity, if they did see a duct injury, they thought it was 90%. I don't think any of this information is true. I don't think that CT scanning is anywhere near as good as they found in this study. What we see on CT scanning is a dark area, and that dark area can represent a laceration, a hematoma, a contusion, or it can simply be fluid. So if you have a minor injury to the pancreas and get fluid around it, it will actually look very similar to this. The duct simply is not clearly seen on CT imaging. And so we did a study where we looked at CT scans or CT plus MRCP in children to figure out what our incidence was at our institution. And we identified 28 children that had a concern for a main pancreatic duct injury. The mean age was 7, so these are very young children, and they often are because this is kind of bicycle age, and a lot of the injuries are bicycle handlebar injuries or motorcycle type injuries. Based on the CT scan, 23 of the 28 patients were suspected to have a ductal injury, though an injury that was more than 50% the thickness of the pancreas. And then 5 patients had a CT scan that looked like they did not have a ductal injury, but acted like they had a ductal injury. They had an elevated lipase, they had peritonitis, they looked like they needed additional studies, and they got ERCPs. The ERCP differed from the CT or the CT-MR in 39% of patients. So 7 patients who looked like they had a duct injury on CT scan or MR had no ductal injury. 4 patients who had a CT scan that said that their duct was an injury actually had a ductal injury. And so CT scanning's sensitivity and specificity, the sensitivity is about 79% and the specificity is about 13%. And then when we add MRCP, it actually didn't add much, it didn't help much. And so the specificity for a ductal injury is 13% in our study. And these are with pediatric body imaging radiologists who at a high volume trauma center. They're very good radiologists, and literally these modalities are not very good at detecting the status of the duct. So the truth number 2 and number 3. Number 2 is that the pancreatic duct is simply not seen on CT. And the truth number 3 is that CT scanning can't allow you to truly grade a pancreatic injury. And that's why we have so much bad data out there. Shortly after we published the grading scale, we got a letter to the editor. And the letter to the editor was from Dr. Rhoda. And he was kind of upset. He said, we had a grade 4 injury based on the MRCP. Then there was no injury found at surgery, and the authors questioned the algorithm recommending surgery for grade 4 injuries. But the real issue is not MRCP. The real issue is that if we use the grading scale and the grading scale is right, then we're accurate. So MRCP just isn't that good. And the truth number 4 is that MRCP is not much better than CT scanning. I want to go back for a minute because Dr. Rhoda showed us the imaging from the study. This is from the Journal of Trauma. And you see the bile duct here. It's very well identified. You see this area here, which he felt was a bile duct injury, but I do think you see the duct here. And so I can't tell you if this is a grade 2 injury with some blood that's showing up bright white or other type of fluid that's bright white, or whether this is a partial ductal injury. But when they got into surgery, they really felt like the duct was completely intact and the patient did well. And so surgery was non-therapeutic for that patient. Can pancreatic injuries involving the main duct be managed non-operatively? So this is really the question. If you injure the duct, do you have to operate on it? And in 1995, Dr. Ono basically published the very first case report of a complete pancreatic duct transection being successfully managed non-operatively. And it was a case report. It was a 17-year-old with a bicycle injury, and they developed a pancreatic pseudocyst, and they got percutaneous external drainage. And he shows the injury, and then he shows it getting better, and then he shows that finally it heals. The problem is that this is not what a pancreatic transection looks like. And so this probably is a pancreatic pseudocyst compressing the main pancreatic duct. In their case, it resolved after 100 days, and they claimed that it was successfully managed, but I don't think that they ever actually had it. So here's a close-up image, and there's no contrast extravasation. That's not what it looks like. When you do an ERCP, this is what it looks like. This is a patient who has a pancreatic ductal injury, and you see contrast leaking out of the duct. And so I think that even from the very beginning, when we were trying to find the truth of a pancreatic injury, we were using data that was wrong. I don't fault him. Back in 1995, we didn't really know much about what ERCP was supposed to look like for a pancreatic duct injury, but now we do. And looking back at that data retrospectively, that very first case report probably took us in the wrong direction. Cucci in 1999 had 5 children with a main pancreatic duct injury, and all 5 of them developed pseudocysts. 2 of them ruptured their pseudocysts. 2 of them required operation. They were in the hospital for 2 months. 1 died of sepsis, and his conclusion was that non-operative management of injuries is effective. I don't consider that effective. I would interpret this data very differently. So this was followed by a paper by Alana Barris, who basically said, is it worth the wait? And she looked at 39 pancreatic injuries that were grade 3 or grade 4. And 15 of the patients were managed non-operatively and 24 were managed operatively. And after they controlled for ISS and associated injuries, the non-operative patients had 8-fold more complications than the ones who went to surgery. They also had 13 more days, 2 extra weeks of total parenteral nutrition. And so is it really worth the wait to not manage these patients with surgery? Well, I think to answer that question, you need a little bit more information, and we'll get to that in a second. But the truths number 5 and 6 are that non-operative management of main pancreatic duct injuries is possible, but healing takes a long time. Does non-operative management of the pancreas save the management the way non-operative management of the spleen saves the spleen? Well, we actually have a great study from Dr. Edwards, and they looked at 9 patients who had complete ductal transection, and at least they thought they did. They took 10 patients, and the median follow-up was 4 years. So they come back 4 years later, and what they find is that in 6 of the 9 of the patients, when you scan these patients, their distal pancreas is gone. Everything beyond the injury for 2/3 of the patients is gone. And so I think that non-operative management in patients with a ductal injury fails to save the pancreas in 2/3 of the time. I will go on to say that I bet the 1/3 of the patients where it didn't atrophy probably had a partial ductal injury and healed. But I think if your duct is completely transected, all you're doing is waiting for the rest of that pancreas to digest itself and absorb. Does operation actually shorten the hospitalization or the complications? Well, there's a multi-center study. We participated in it, 162 patients. And when they looked at the patients who underwent distal pancreatectomy, and they looked at the ones who were managed operatively and non-operatively, and the distal pancreatectomy patients, the patients who had their pancreas taken out, were quicker to goal feeds by about a week. They did not develop any pseudocysts compared to 18% in the non-operative group. They had fewer endoscopies, 2% versus 21%, and fewer interventional radiology procedures, 0 versus 18%. They just did better. So for patients with injuries to the body or tail of the pancreas, distal pancreatectomy is superior to non-operative management. Can you do this operation laparoscopically? Absolutely. There's more than 7 papers now that they're all retrospective and they're all small series. But the operation itself is actually not very technically demanding. And the reason that it's not technically demanding is that when you get in there, what you find is that the pancreas has already been transected. So the hardest part of the operation, cutting the pancreas in half, has already been done for you. So you just complete that, and then you take out the tail of the pancreas. And here, this is the pancreas right here, and this is where we've completed the rest of the transection. And then we do go back and we oversew the proximal side of the pancreas. But when you do that, and this was published by Iqbal, they basically looked at 14 open and 14 laparoscopic, and the operative time was about the same. The length of stay was shorter if they did it laparoscopically, and the morbidity really wasn't different between the two groups. So truth number 4 is that you can do this operation laparoscopically, and it's not very difficult. Does pancreatectomy lead to diabetes later in life? Well, if you resect less than 50% of the pancreas, there's no abnormal glucose tolerance testing. So these patients don't have diabetes, and most of them don't go on to develop diabetes at a higher rate than the general population. If you have a 2/3 resection of the pancreas, then those patients do have an abnormal glucose tolerance test. Even if they don't have diabetes, they do have abnormal tolerance to glucose. In adults, less than 8% of patients develop diabetes after distal pancreatectomy and long-term follow-up, and the ones who get chronic pancreatitis are the most at risk. So truth number 10, if you resect less than half the pancreas, it's very well tolerated. So what are our options to save the pancreas? So if not operating on it doesn't save the pancreas, and distal pancreatectomy certainly doesn't save the pancreas because you resect it, are there any other options? Well, the Roux-en-Y pancreatic ojegonostomy, this used to be called the Letton procedure, is very well described. And they looked at 10 patients, and it was equivalent to distal pancreatectomy and morbidity, so it wasn't any worse than doing distal panc. It avoided the pancreatic atrophy, and it was a good option for cases where they thought that more than 50% of the gland might need to be taken. This is a patient of mine, 5 years post-op. I'm sorry, it's grainy. So what we see here is that the pancreas is completely saved. This dot of air that you see right here, that's in the jejunum. And so we do know that Roux-en-Y pancreatectomy saves the pancreas. There's one other option. I've never done this personally, and that is taking the end of the pancreas and plugging it into the back of the stomach. It's well described. In this series, they had over 100 patients, and so it is a surgical option, even though I haven't done it. And this is what their picture looks like. Truth number 12, surgical options exist for saving the pancreas. This study basically said, no, you don't have to operate on them. They all do fine, and they do just as well. And they didn't separate out the patients who had ductal injuries for those who didn't have ductal injuries, and they assigned the patients who failed non-operative management to late surgery to the operative group. So if you try to manage them non-operatively and they fail, they just reassign them to the other group. I think that's evil. You can't do that. You need to manage these patients on the way you intended to treat them. And so truth number 13, be aware of bad science and large database studies on pancreatic trauma. Truth number 14, after a week, the abdomen looks like this. And so a lot of the recommendations I'm giving you are for acute trauma where you identify it early. And that's why it's so important that we do the studies and we find out what the status is, because after about 6 days, it's going to be a much more difficult operation. It's going to be hard to do laparoscopically, and the operation itself really becomes much more challenging. So, the truth about pancreatic trauma. The pancreas is not the spleen. The pancreatic duct is not seen on CT. CT scan misses a lot of injuries. MRCP doesn't add much. Non-operative management of the injuries to the main pancreatic duct is possible, but healing takes a long time. Non-operative management of patients with ductal injury fails to save the pancreas in 2/3 of cases. Distal pancreatectomy does not lead to diabetes later in life. laparoscopic distal pancreatectomy is surgically feasible and is not that hard, and that there are surgery that can result in pancreatic salvage. Beware of large database studies, and surgical options become challenging after several days. Now, my final thought, pancreatic trauma is really a duct injury problem, and ERCP is the most reliable way to assess the pancreatic duct. Controversy still remains in stable patients with grade 3 or higher injuries, but I think that we're starting to understand that the truth is that the duct is what matters. Thank you. I'll take any questions.